Okay, good evening, and thank you to NanoString for inviting me. So I'm going to look at a little bit about the clinical validation that we have for Prosigna as a genomic signature for the management of early hormone-positive breast cancer. These are my disclosures. And just as a background, we need to take into account that we're really experiencing a very significant paradigm shift in how we treat and evaluate breast cancer. So if one size mattered and we staged breast cancer only by T&M staging, we can see now with the new AJCC 8th edition of breast cancer, cancer staging, that we actually are already there incorporating the molecular profiles into how we're staging breast cancer. We're slowly shifting over from simple pathological profiling of solid biopsies over to omic profiling and liquid biopsies. We are slowly making a shift from the large clinical adjuvant trials where we included thousands of patients in a non-targeted manner to more window of opportunity studies, including neoadjuvant models, randomised phase 2, Bayesian models and biomarker-driven studies to have a more rationalised approach to how we evaluate new medications. And we're making a very slow shift over from traditional chemotherapies and hormonal therapies to integrating molecular targeted therapies and possibly in the future immunotherapies for our patients. And as already demonstrated this evening, this pivotal paper by Chuck Peru was published 18 years ago in Nature, and this was the first description of the intrinsic subtyping. This was later confirmed by the paper by Sawley, where we saw these gene expression patterns. And really these papers were probably the most pivotal papers in breast cancer research, I would say, in the last 20 years, because they changed the way we viewed breast cancer, they changed the way we classified breast cancer, and they've probably changed the way we treat breast cancer. And more importantly, if we think about it, they've really changed the language in the way we describe breast cancer and discuss breast cancer, and probably in a way no other studies have done in the last 18 or 20 years. A group of researchers were then able to take this model and develop the PAM50 model for generating the intrinsic subtypes. Now, we know that often both intuition and science and preclinical data don't always translate into evidence-based medicine. We see that whenever we see a negative study that we all assume would be positive. And so what's really important, especially when we're looking at biomarkers or new technologies, is to establish that we have analytical validity, that we have a clinical or biological validity, and that we have clinical utility. And so for the rest of my talk, I'm going to focus on the issue of the clinical validity of Prosigna. And we're going to look at three key studies, the TransAttack, the ABCSG, and the recently published Danish Breast Cancer Group study. So the TransAttack study was based on the ATTACK study that was looking at a comparison of tamoxifen and anastrozole, and there was a pre-planned project to do translational research on the tumour blocks that had been collected there. The samples were collected and they were used to evaluate a variety of models of molecular profiling tests, including the Oncotype DX as well as PAM50. And there were over 1,000 blocks available to do this. And what we could see was that in terms of the disease-free, relapse-free survival, we could actually, in the node-negative group, see three distinct risk groups, with a low-risk patient who had less than 5% probability of a distant recurrence at 10 years. And the difference between these three risk groups was in fact statistically distinct. We saw that approximately 58% were classified as low risk in this node-negative group, 24% were intermediate risk, and 17% were high risk. This breakdown is actually quite similar, not identical, but similar to what we also see with some of the other molecular profiling platforms that are available. When we looked at the node-positive patients, we could also see three distinct groups. And in fact, the numbers are very small, but in this very small group of node-positive patients, in those who were categorised as low risk, there was no events of recurrence in the follow-up period. And in the intermediate risk group, the level of recurrence stood at approximately, it was 11 patients at that time, but it was a small number of patients. When we looked at the ABCSG, this was another clinical validation study. This was also a study looking at postmenopausal women being randomized to tamoxifen or tamoxifen followed by an aromatase inhibitor. And in this study also there were well over 1,000 blocks that were available for evaluation. And again, if we look at the patients separately in the node negative and the node positive group, if we start with the node negative group, we can see that approximately 47% of these patients were classified as low risk, with 21% classified as high risk. And then in the node positive group, we can see, in this case, just two lines on the graph. One is the low and intermediate group, and one is the high risk group. And interestingly enough, in the node positive group, we can see already here an indication that there's a significant number who are not high risk. In fact, only 41% were low to intermediate risk compared to 59% who were high risk. And the risk of disease recurrence in the low to intermediate risk group was in fact only 6%. And I just want to mention that there have been a multitude of studies looking at the PAM50 subtype testing in various studies. And I mention this because at the moment we're looking at the prognostic value of Prosigna, but we need to remember that the basis of the Prosigna is the PAM50 subtyping, and that in PAM50 subtyping there are many studies that have been done that indicate that it has predictive value in terms of the value of chemotherapy. The most recent publication of great interest is the Danish study that was recently published in the JCO at the beginning of this year. This study was really interesting, and in fact even was evaluated by accompanied by an editorial. And this study looked at all postmenopausal patients in Denmark who, by national guidelines, over a 3-year period were allocated to 5 years of endocrine therapy only as their systemic treatment after an initial diagnosis of hormone-positive breast cancer. We know that the Danish groups and many of the Northern European countries are really very structured in how they run their databases, and you apply their clinical guidelines for treatment, and we can actually learn a lot often from the studies from these Northern European groups. The eligible patients here were over 50 with at least one of the following risk criteria: a tumour over 2 centimetres, ductal histology of grade 2 to 3, and 1 to 3 positive lymph nodes. So what we could see was that there was an initial group of 2,500 patients. Some were node negative, some were node positive, and Prosigna testing was performed successfully on most of the patients with few technical failures. And there was a long-term follow-up of a median of 9.25 years. Important to point out is this is a high-quality, prospectively maintained database that is rigorously maintained. And what we could see here is that you could actually somehow see a continuous relationship between the 10-year risk of recurrence score and see this in relation to the number of lymph nodes. And this very nicely illustrates, you can see here how this divides very nicely according to the number of lymph nodes involved, from 0 through to 3 lymph nodes. And I think this is very interesting because it really shows us how the incorporation of the anatomical burden can have some value when it's done in incorporation with a molecular profile. The major findings from this study with regards to distant recurrence at 10 years were that in the low-risk group, in the node-positive patients, we can see that there's a group that only had a 3.5% risk of recurrence, even though they were node-positive. It successfully demonstrated 3 risk groups of patients in high to intermediate risk groups for those who were node negative, those who had 1 positive lymph node, those who had 2 positive lymph nodes, and in the patients who had 3 positive lymph nodes, the patients mostly divided into 2 groups, with no recurrences seen in those who classified as an intermediate risk group. And as I already mentioned, all the patients categorised as low risk, regardless of their nodal status, had an absolute risk of distant recurrence of equal to or below 5%. So this would be definitely a group of patients we could certainly consider not having to give chemotherapy to if they've got such a low risk. What we also saw with this study is that the behaviour between the luminal A and the luminal B patients is distinct, and it is distinct both in the node negative but also in the node positive patients. And if you look at node positive patients with 3 lymph nodes, if they are a luminal A subtype, their risk of recurrence is just under 10% at 10 years. So we know that regardless of their nodal status, the luminal B tumours are going to do significantly worse than the luminal A tumours. In conclusion, the Danish study confirmed in a large nationwide clinical practice setting the validation data that we had already seen from both the ABCSG, the TransAttack, and also there's been a combined analysis of those studies previously performed. We saw that all patients in the low risk, irrespective of their nodal status, had a distant recurrence risk of less than or equal to 5%. Prosigna could identify 26% of the node-positive patients with a low risk of disease recurrence at 10 years. And by tailoring a risk categorisation by the number of positive lymph nodes, we could see that 37% of patients with 1 positive lymph node are going to be low risk in this data set, and 15% of patients with 2 positive lymph nodes are going to come out as low risk as well. And again, once again, and we see this consistently in all the studies, that the difference in the outcome between the high, the intermediate and the low risk, both in the node negative and node positive patients, is significant. And in conclusion, we can see that the luminal B tumours, as we've seen in many studies before, have a significantly worse outcome than the luminal A patients, irrespective of their nodal status. So how much extra added value does a Prosigna test give us compared to clinical prognostic data? So this paper was recently published by Ivana Sestak. This was a paper that was presented several years back at San Antonio. And this was looking at a comparison of the performance of 6 prognostic signatures as a sub-study of the TransAttack group. And it was actually looking at a comparison of the clinical treatment score, which was based on traditional clinico-pathological features, and then it looked at these different platforms to see how much extra information did they actually give us when trying to understand the prognosis of the patients. The objective was to conduct a within-patient comparison of the prognostic value of these different multi-gene signatures in women who had early hormone-positive breast cancer in the TransAttack dataset. And the objective was to assess this both in the node negative and the node positive for distant recurrences and late distant recurrences. And what we could see was that for years 0 to 10, in the node negative population, the platforms that gave us extra information was, we could see some extra information given from all the signatures, but the signature that gave us the most information as added value on top of the classical clinical characteristics was in fact the ROR score that provided Prosigna, and this actually improved our prognostication by nearly 75%. And what we can see that with the ROR score, the risk of distant recurrence was 3%, which is this number that we keep seeing for the low risk group, and 33% for the high risk group. When we looked at the patients with node-positive disease, we can see that all the platforms give us less information than they did in the node-negative setting. However, they still did give us some information, and the platforms that really gave us the most information were the BCI, the ROR, and the EpiClin scores. And in this setting of node-positive patients, the ROR improved our prognostication above that we had from basic clinical data by 46%. And in this case, the numbers are small, but the risk of recurrence in this very small subset of low-risk group was 0. The intermediate risk group had a 20% risk and a 30% risk for the high-risk group in the node-positive setting. And I think this last slide on this group is quite interesting. This was looking at the risk of distant recurrence amongst node-negative and node-positive patients. And what you can see here is that for the BCI platform and also for the Oncotype DX platform, even the low-risk group patients, when you looked at long-term recurrence risk, these patients actually had a 15.5% or a 19.4% recurrence risk. This is probably by definition of most of us, not really a low-risk group, whereas the ROR and both EpiClin were able to identify groups of patients who really, in terms of if they classified as low risk, they truly had a low risk of recurrence. And again, looking at the late distant recurrence in years 5 to 10 in the node-positive patients, we can see that in the Oncotype DX recurrence score, we can see that even the low-risk group, coming close to 10 years, their recurrence exceeds 10%, whereas if we look at the ROR, those who had a low-risk group maintained a very low risk of recurrence over time, as did in the EpiClin platform. In terms of the strengths and limitations of this type of study, well, there was mature clinical data with long-term follow-up. The tissue samples were well characterised, the same extraction methods were used for RNA extraction, and there were standardised methods and analyses performed, and the collaborators were blinded to the clinical outcomes. There are, of course, limitations with these types of studies. The results are only applicable for chemotherapy-free postmenopausal women because this study was a study on endocrine therapy in postmenopausal women. We need to take into account that some of these platforms were trained on this TransAttack cohort and that the risk group cutoffs for the ROR were in fact defined on this TransAttack cohort, and this is always a limitation when looking at that type of cohort again. The ability to predict the benefit from chemotherapy or extended endocrine therapy cannot be assessed because it was not assessed in this study. So while this helps us predict who is at late risk for recurrence, we need to be careful before we draw conclusions from that whether we can make decisions based on this information about extended hormone therapy. So in conclusion, in the node-negative patients, all the signatures provided additional prognostic information, but not to the same extent. And here we could see that the Prosigna ROR score really provided the most amount of added benefit information in addition to clinical trial information. We had very good risk stratification into patients in low-risk group. In the node-positive patient, the prognostic strength is weaker for all the genomic tests. However, the ROR and the EpiClin identify a proportion of women who are truly at low risk if classified at low risk. As I already mentioned, the other platforms, their low-risk patients actually didn't have such a low risk of recurrence at 10 years. So my take-home messages would be that we are seeing consistent data for Prosigna in both the node-negative and the node-positive patients in large clinical trial datasets. We have robust data in both the postmenopausal women for short-term and long-term recurrence risk. I think one of the benefits of this particular platform of Prosigna is that it does incorporate the anatomical burden into the signature and the risk categories, as we can see here. And in terms of other studies that are ongoing, including prospective randomized clinical trials, there are a wide range of studies going on for a wide range of therapeutic questions using this platform. And what's very convenient about this platform in the clinic is that it really speaks the language that we as clinicians have been using now since the pivotal studies by Chuck Peru's group. It speaks the language that we use every day by providing the intrinsic subtyping, and in that way it does definitely assist us in clinical decision making. I'd like to thank you for your attention and just take the opportunity to promote BCY4, which is the SOSMO sponsored program for breast cancer in young women. The conference will be taking place later this year, and you're all invited to attend. Thank you.